A quick down and dirty of pancreatitis, various causes, but number one in the United States is gallstone pancreatitis. Number two is going to be alcoholic pancreatitis. Okay. And then number three, most common, is the hypertriglyceridemia pancreatitis. Okay. And number four is going to be probably the post-ERCP pancreatitis. And then we got a bunch of other causes right here. You can have it from trauma. You can have it from autoimmune, annular pancreas, pancreas divisum. I remember learning about a scorpion sting. Probably super rare. All of these can culminate in acute pancreatitis. Not all pancreatitis, however, are equal. You can have a mild form, mild pancreatitis, and this is treated conservatively and all is well. However, you could absolutely have a severe acute pancreatitis. And what distinguishes these mild from severe is the presence of organ failure. So, kind of two ways that two main ways, but there's a number of things that can happen with acute or with severe pancreatitis. Can have an edematous or a non-necrosing pancreatitis. Could also get a necrotic pancreatitis. And these are, so usually people have a pancreatitis and it resolves. As we move to the screen right or page right, these are things that can happen as sequelae. They're less common as we go along, but also more morbid, even with a higher mortality. And really, technically, another thing that can happen, I mean, you can have a variety of things. You can have cholangitis that occurs with the gallstone pancreatitis, but I'm going to put here hemorrhagic pancreatitis. Okay. The way that this is manifested can be within a certain time period. We have time less than 4 weeks. It's important according to the Lanta criteria, and then greater than 4 weeks. So here, a lot of the times as it goes on this long, you'll start developing a fluid collection. And if it's before 4 weeks and it's a non-necrotic, it's called acute peripancreatic fluid collection. Okay. When it's necrotic and it is less than 4 weeks old, this will then be called an acute necrotic collection. The treatment for all of these is the supportive care. And one time, we'll go over the treatments here in a moment, but treating all these individual etiologies. However, when it's past 4 weeks, when it's an acute peripancreatic fluid collection, it persists. It's called a pseudocyst. By this time, it had formed that layer, that capsule, and is now a discrete cyst of a sort. It's not epithelialized by any means, but it's still a cyst. Pseudocyst, not a true cyst. And then our acute necrotic collections are called walled off necrosis. Also WON is another way that it's, okay? Either of these at any time can develop a pancreatic abscess, which usually occurs after the 4 weeks. It can occur before, but usually after. Okay. So the treatment for all of these, let's go back to gallstone pancreatitis. Often they'll probably need the ERCP and then a cholecystectomy prior to discharge. My check mark here is just going to equal your typical pancreatic management supportive care. Okay, that's what that represents. So alcohol the typical management here, as well as alcohol cessation. You stop drinking. For hypertriglyceridemia, again, control the pancreatitis, and then control our triglyceride levels. Post-ERCP, it's just an unfortunate event after having their ERCP. For autoimmune, get them through this episode. You also start your steroids for them. Annular pancreas, you don't resect the annular portion. You will get them through the pancreatitis if they even get it. Usually annular pancreas is asymptomatic, but you would do a Roux-en-Y gastrojejunectomy, bypass that area. You could also do a duoduodenostomy, but really probably the most user-friendly for them is going to be a Roux-en-Y gastrojejunectomy to just bypass that area. Pancreas divisum or divisum, get them through that episode, and then ERCP with a sphincterotomy and a stent placement. And then really, if this doesn't work, also kind of a similar, there's procedures that could be done, open procedures, anterior duodenotomy, etc. Scorpion sting, move to Montana or something. Acute pancreatitis, get them through that episode, treat their underlying factors. Severe acute appendicitis, pancreatitis is treatment of the underlying etiologies, of course, and then that supportive care. Again, when we have these conditions, you're still going to treat the pancreatitis, get them through it. For hemorrhagic pancreatitis, you're going to angioembolize the bleeding vessel. If that does not work, if that fails, you can do surgical hemostasis. Open them up and get control. Obviously with a high mortality. Pseudocyst. These, again, are more likely to resolve on their own, but if they develop symptoms or if they're greater than 6 centimeters, you're going to go for a cystgastrostomy. Internal drainage is preferred. That's usually if it's more towards the head. Again, you may have cases where there could be the pseudocyst is at the tail, it's not reachable endoscopically. Well, then that's when you could do a Roux-en-Y cystgastrostomy, bringing up a Roux limb and making that connection with the tail, or the pseudocyst at the tail of the pancreas. Walled-off necrosis, percutaneous drain. And then I'm going to put here step-up approach. It's all part of the Atlanta guidelines. What this is you place the percutaneous drain, you upsize it, and if that fails, then you do video-assisted retroperitoneal dissection, or debridement rather. And then really, if these fail also and the patient is not doing well, necrosectomy, an open necrosectomy. There's also you can do endoscopic if the facility has the expertise for that. But that's kind of the upsizing or the step up progression of that. Pancreatic abscess is manifested by a collection plus signs of infection, fever, leukocytosis, error on CT scan. Ultimately, what we need is sampling of that to confirm. But you don't have to have that. When you have those signs, confirm, not necessary. When you have signs of pancreatic abscess, you're going to start ertapenem or ertapenem, antibiotics that have the ability to penetrate into pancreatic tissues. So ertapenem, you're going to start antibiotics, okay? And you're also going to place a percutaneous drain if this fails, okay?